I really like this presentation from the World Council of Optometry of the progression of optical correction over 800 years, the slow evolution through and the enthusiasm for laser refractive surgery at the end of the last century, and literally the last few years where we've got into proper myopia management. But along with that has come a lot of complexity. We've gone from nothing at all to quite complicated regimes. There's mitigation, measurement and management, and analyzing efficiency, all of which require experience, tools and techniques which we have to make up as we go along. This is the zoomed in box of that, what that new era looks like. There's a lot of things that we have to discuss with parents in terms of lifestyle behavior, the options, the management and the implications of treatment and not treatment, which brings a real sort of emphasis on the need for patient communication, probably in a sort of better, slicker way than we have done to date. So in 2024, Myopia Control is in an odd place, which is there's a bunch of cool kids, I call that, on the bus, or, charged into this, and great enthusiasts and early adopters. But it's happened so quickly that the vast majority of practitioners are still trying to get their sort of heads together around this, and recent surveys as of last year, it's still a minority of people. It's getting close to 50% now, but still an awful lot of people who haven't yet embraced it. And part of that, I think, is the fault of some of the people who've led this in the first place, which has made it seem more complicated than it is. Now, there are definite barriers. We did a lot of work with one of our PhDs, Saoirse McCrann, a few years ago, identifying with talking to practitioners, students and educators about this field. And there's a whole range of different topics came up. So I'm going to zoom into some of them. So in terms of the human factors, parental awareness of myopia as something which is worth treating as opposed to just correcting, and also within the broader area. Confidence and training barriers are a huge issue. Most people dealing with this now weren't taught this in college, after sort of learning it afterwards, and a lot of concerns about the evidence and the variation in guidelines of how to actually get that sort of level of confidence up. Practice factors is something I didn't appreciate particularly at the time when we did this sort of work, but a couple of very specific features about chain-based optometry, sales and performance-driven environments, and the dreaded chair time, and follow-up care. This is going from a transactional fitting glasses to a much more long-term relationship, and therefore with locums, people and multiple people in the same practice, that continuity can be a problem. And technology barriers, as guidelines get more complicated, people will advocate that you have to have a topographer, which you need for certain types of treatment, but not all, and also axial length measurement is a key thing, and I'll talk about that. One thing that is less well talked about is the fact that anyone actually offering these treatments, I think, is acutely aware of the fact that they're not cheap. Currently in Ireland, there's no reimbursement. I'm guessing outside the high refractive error bracket that we have in the Dublin region under the under 12 scheme. As of last month, the big breakthrough was Switzerland was the first country to recognise and fund it. And I first heard about it, it seemed to be sort of a carte blanche, but it actually is a little bit more specific to that, requiring evidence of progression and a likelihood of ending up as a high myope at the end. So that also then requires tools for prediction. One avenue which Eoin will talk about later on is the fact that we've moved from trials where we're comparing, say, atropine with a placebo, so some of the kids don't get any active treatment, to open label trials where everybody will be getting access to an intervention, and we're just monitoring those against historical cases. And in those trials, the lenses or the contact lenses are provided by the company free, so that's a huge upside. So I'm going to give a really brief talk about the evidence. Sometimes people can spend hours doing this, but I'm going to give a really sort of whizzy talk to this. I spent 4 or 5 years of my life looking at atropine, and multiple clinical trials here in Ireland. Some of the biggest European trials have happened here, and also involved some of the multi-center trials from the US. And to condense 5 years of my life into about 5 words, the results are on the disappointing end for sure. Compared to in Asia, we're not seeing the sort of level of treatment effect we expected. We've just finished a higher dose range in one of our last trials, 0.05%. That's definitely showing some much better performance, which ties in with some of the results from Asia. The big problem with Europe is it's quite regulated. There are, you can get it, but it's not licensed. It's all grey imports and of very variable quality, which is a concern. But there are forms of atropine which are used and prescribable with the higher doses, which obviously have a lot of side effects, but you can use those in creative ways to get the benefits without some of those side effects. And I'll give you some cases about that. Optics really are winning the show right now. They have 2 main advantages. A, the evidence that they're effective is actually much stronger than it is currently for atropine in European kids. They also have a much faster route to market. In Europe, getting a drug to the market is an incredibly slow process. It's in fact an oddly speedy process for glasses because it's a self-certified process because they don't actually have to prove efficacy in Europe, oddly, so the evidence all comes from outside. But Stellest and Hoyer have really good evidence in China and growing evidence in Europe. We're doing one trial with Stellest. Zeiss Myocare, new kid in the block, being sold hard, similar principle, and the initial results seem to be as good as the others, but the follow-up is much shorter. Obviously, my site, which we know well, is the only FDA-approved lens that has probably the best evidence for long-term data in Europe and USA. Other contact lenses, center difference bifocals, which we use a lot for kids who require toric, and then obviously orthokeratology, a bit of a minority sport, very effective, but needs dedication. Red light is bubbling up. Very lot of noise from China, and some of these devices are now coming onto the market in Europe. So if you've had a chance to look into this machine, but I have real concerns about the light exposure, and there have been 1 or 2 cases of foveal damage from that, and a lot of anecdotal data that a lot of cases in China are not being reported because of various societal pressures. So if you are starting out, or you're trying to you're already in practice and doing it, and you're trying to get your other colleagues to get on board, I absolutely always start with optics first. I do not start with atropine in any cases. And my simple recommendation is there's a range of choices. You just choose one that will suit your practice and type of patients. The big game changer obviously being glasses. They're the easiest of all things to prescribe, despite obviously the slightly higher price. Contact lenses. Now, in hospital settings, we put 10-week-old babies into contact lenses if they have congenital cataracts. So actually, we are fairly sort of risk immune, I think, when using contact lenses. But fitting kids under 10 to lenses is it really can be very successful if you follow a few simple rules, which is, I always say that an enthusiastic child and a nervous mother is fine. A pushy mother and a nervous child will always end in disaster. And look for the motivator. If there's a single factor I think will predict whether a 10-year-old will want to wear contact lenses, if they turn up in a GA jersey. You've spotted they're sporty, and that's the biggest single sort of motivator for getting kids into contacts. Trying to, I'm sure, play any sort of GA sport in the rain with goggles without windscreen wipers on your glasses, and then steam up as well, so they're a disaster. And a lot of my patients end up with mixed solutions, so it's not just glasses or contacts. So they'll often wear the contacts for sports, have the glasses in the school, and then will slowly morph into full-time lens wear as they get older. In terms of the hesitation, people are often worried about getting into a long conversation. And sometimes there's definitely get the sense that people sort of are worried about what if they say know. There's a slight sort of dating sort of aspect to myopia control. You have to remember that the UK College now has moved the dial for what the standard of care is to, if you're not doing myopia control, you have to at least tell people it exists. So if you, you know, I know I'm mentioning it because of the cost, you don't think it's unexpected. If you don't mention it and they come back a year's time and their neighbours' kids have been in classes and they haven't changed, and their kid comes back up a year later and there's a big jump, they are understandably going to be, and every right to be, sort of reasonably unhappy about that. If they said no and you've told them and they come back and the glasses have changed, it's a really simple conversation. So it can be easy to sell on the first prescription if you present it right. But if you just mention it, sometimes it's a very easy sell on the second prescription. One thing that's odd about how people have started into this is that they're, I'm sure everyone understands that the earlier you start, the better the ultimate impact you'll have. But people tend to delay starting until kids are quite myopic, and I'll show you some evidence on that from Ireland. So definitely start early. The other caveat is that, and I'll show you some cases of this, which is that it's never too late to start. So people might, you might think a kid's turning up who's already very significantly myopic. What's the point? And in terms of what we're trying to achieve, which is persisting, keeping their eyes healthy into old age, then there's an equally very strong benefit for slowing down some of the very advanced cases. And I'll show you some of those. And I really want to emphasize the fact that people disagree with me with this, but you really do not need axillary measurements to manage and start treating kids. All these interventions are licensed and sold on the basis of treating myopic children. As long as you can confirm they're myopic with a cycloplegic refraction, then you're good to go. It can be really helpful. And it's really helpful in complex cases. And I think there's a great scope there for shared care between optometry and ophthalmology in some of the odd cases I'm going to show you later on. But about intervening early as possible. Michael Moore, one of the guys who works here, did a great paper looking at prescribing patterns in optometrists. And this was a few years ago, the data. But the average age we're starting is 3.5 diopters. So we're actually quite well into the myopia journey, and we'll have a much bigger impact if we're starting earlier. The other thing about getting kids into glasses earlier is once I have one family in the room, I want to know everyone in the family who's myopic. Is the older kid, are they still progressing? Is there a younger kid who has not in glasses yet? And if you're dealing with a myopic adult and there's no kids in the room, ask about their kids, and if you can get them just as they're, becoming short-sighted, and start treating, then you will, have a chance to really change their outcome. And there's a question which I always, if I'm seeing a sort of a younger sibling and they're just big sisters in glasses and they are sitting at sort of -1/4, don't need glasses yet. The question I'll always tell the kids, to tell the parents to ask their kids every now and then is, do you ever have to ask the person next to you what's on the board? I'm sure any of you out there who are myopes, I absolutely guarantee you spend about a year or two doing that yourselves at school. And it's amazing the number of parents who are myopic, their kids will turn up at -2, -3. But that one question is an incredibly good screening question. And I'll say to the kids, look, if you ever do, just come back home and tell your mum, and then we'll get you checked. So I want to talk about a few interesting eyeballs. And also going to show you some of the tools that Optometrist is a company, is a spin-out company from that. So we've poured all the research and the science we've been doing over the last few years into tools with a mission of trying to make myopia management easier, faster, more evidence-based, and ultimately, hopefully, more successful. I see a sort of a probably different bunch of myopes than most people in community optometries, because I get a lot of referrals, from the community. But simple myopes, what I call the vanilla myopes, if a 10-year-old with -1.5 turns up with a pair of glasses, have that conversation. The challenge is how to have that in the most effective way. But you also need to think about the unusual cases, because the ones that get referred to me, they haven't been filtered out unusual cases. They're usually sent to me as saying, please treat with atropine, without realizing this is quite a different type of myopia. So my sort of mental checklist is always just look in the family history. How surprising is this kid? Is this kid -7 and everyone else is emmetropic, which is a bit weird. Is a particular strong pattern is where you have half the family are absolutely fine and half of them are -10, screamingly genetic pointer. What's causing this level of myopia? We know axial length is a key factor in myopia, but it's not always. And we've developed some tools for working out actually what's causing it, and that's quite an important thing. Very rarely, there's the 1% of kids in the highest range have a very high risk of having genetic syndromes associated with this, which are very commonly missed, but are very important to manage. How worrying this is relates to how bad they're going to get and the implications of that, and covering both the refractive measure itself and also the axial length. And then when it comes to actually treating and also monitoring treatment, you need to have some benchmark to know that are we progressing faster than normal with or without treatment? How well are we doing? It's really going to be a really key thing when they come back a year's time, having spent a lot of money potentially on an intervention, to be able to have a clear message about how well it's working. So I mentioned about it's never too late. So this was a kid who was sent in. He's 10 now. He's 10 and he's -4.5 already. The family history, he has a maternal grandfather who was also very high myopia, which points to a possible X-linked pedigree if you're into the genetic side of it. But there's a whole series of things we've run through, and I'll tell you about some of those later on, in terms of normal color vision, normal best corrected vision, no syndromic features, nothing else worrying the family. But his axial lengths for a 10-year-old at 26.2 millimeters, averaging up, unusual, and his keratometry is flat, and that's the classic sort of warning sign, even without the axial length. A myopic kid with a low power cornea or a steep cornea in millimeters is almost certainly going to have surprisingly long axial length. So my guide, one of the things I mentioned about in terms of communication is a tool we've put together to just put the basic levels in of a kid's gender, we adjust for race, their age, the refractions. You can put in axial length. You can also put in the keratometry directly, and we can then give you an estimate of axial length based on the paper we also just published. And what this produces is it's designed to be a structured conversation, which, if you look at the UK College guidelines about all the things you should be talking about in relation to myopia care, is in this list. There's a QR code there. If your phones are working and you want to scan as well I'm talking, I'll leave that on the board for a minute or so you can get have a chance to scan it and load it up. And you should be able you'll be able to see the contents of this report on your phone. You'll be seeing the full so ECP version of it. When this is used in practice, there's a QR code pops up which actually allows the parents to see a rather simplified version without too much detail about axial length, so it avoids you having to explain too much. But the point here is that this conversation allows you to choose a conversation. You kind of start at one end and go through, but we're not expecting you to do everything. The main point here is that if you start to describe a kid's eyes to the parents, the first section just answers that question: how unusual is this kid? I mean, they're already just off the top of the chart, the 99.9s surrounding up to 100. This is a very unusual myopic kid. Now, this kid's going to be projected to be at least, by the time they stop growing by 20, twice as bad as they are now. That's going to be a very strong motivator. For a less myopic kid, I mean, you can have a -2 7-year-old. Doesn't sound too bad. Mum's sitting there at -4. And as soon as you tell her that their kid is probably going to be significantly worse than they are as an adult now if we don't do anything, they will want to immediately jump to the treatment section. So this is what I call like the Jerry Maguire film. Remember that one? You had me at hello. You can sometimes just present one thing, and parents are attuned to percentile charts from their kids growing up. And literally you can go straight from that to the conversation. You don't have to discuss every single part of it. You've also had a vision simulator. It's very useful for parents who don't wear glasses. Now this kid obviously is starting very blurry and going to end up much more blurry, but this can be a very convincing story, particularly in those early myopes. And this is interactive, so the parents can play with that and see the two eyes, and it takes account of the blur and the astigmatism as well. If you have axial length data, one of the big problems with axial length is that people, when they measure it, it's like, okay, well, what does that mean? If I asked, any number of ophthalmologists or optometrists, what's an 28-year-old's axial length typically, as a girl, and our girls and boys different, they look a little bit sort of blank. So and they have the same problem explained to parents. If you're measuring it and say, well, what does that mean? So we can already measure exactly from an age-matched norm that this, for his age, is already 2 millimeters longer. Like his refraction is off the chart. And we can also project this forward to understand what that adult level is. And that is, extremely dangerously high. We can also give the risks and benefits. This is there for completion. It's on the report that the parents can take away. Very useful, particularly if one parent's there and the mum or dad wants to sort of discuss it later on. I often get parents in they work at Google. They're kind of into this section. They want, give me some numbers. But we can look at what's the risk of vision impairments without treatment or with treatment. And this is a case of why it's never too late, is that these kids who are very myopic, by the time you get to -5, one more diopter has a much bigger impact on your future ocular health than going from -1 to -2. So actually, there's a significant, the benefit for ocular health really kicks in the higher myopes. The benefits for visual performance and unaided visual acuity is much better if you intervene straight away. And also, we on the basis of the growth and the efficacy, we can give you, if you come back in 6 months, 12 months, or what's the ultimate target, exactly what you're aiming for. So it takes away the what do I do with this number? Axial length gives you an awful lot of extra additional information. Now, this is another tool that we've developed. This is actually developed in CERI, and this is the first way of actually graphically looking at an eye and understanding what's causing it to be short-sighted. So this kid, this is this refractive mechanism map. The triangles sort of just emphasize the key area. This is axial length, the lens and the ACD position, depth, and the corneal power. So this kid, they're 4.5 diopters of myopia, but their axial length is much bigger than expected. This is what I call super myope. So in fact, in terms of axial terms, they're already a high myope. Now, if you don't have a biometer, what can you do? Well, the MyGauge, which is a free feature on the platform, or can be incorporated with the MyGuide, you can just, if you add in the Ks, we've from 10,000 normal eyeballs, we've created a machine learning model which will give us a reasonably accurate prediction. This is within 0.1 millimeters of in this case, but again, is pointing out that this eye is extremely long, the increased risks. So we can get all that information. And the great beauty about the estimation is that it gets you sort of trained up on understanding axial length. I think it's a really sort of valuable, underutilized tool. So thinking about this kid, he's very high. Might be some genetic features, but we haven't found anything to worry about. So we really get emphasis on the axial length. On the basis of the referral information, he was already progressing pretty fast. So for this kid, because of his extreme axial length, myopia is an absolute must. So for him, what I did, and I would normally do in this situation, if I'm expecting I want to be very aggressive about treatment, and I'm thinking I'm probably going to use dual treatment, I get contact lenses first, and the next case will explain why that's beneficial. And I'd have a very low threshold for adding atropine, but I'm going to be using the myopia control aspect of the contact lens to mitigate against the side effects of atropine. And here's a young lady who's so kind of further on from that kid, similar sort of picture, very highly myopic, eye-wateringly long eyes, and referred in by a optometrist, very organized and good myopia practice with axial length measurements, no strong genetic factors, but she's super high, and she's been on treatment, but she's actually progressing more than she should. So this is, for example, this is a centile chart for both of her eyes. So like the other guy, he's kind of off the chart. We already know this is a very unusual high-risk eye. In terms of assessing treatments, these are some of the new graphs we've developed. These aren't yet released, but they will be released in the coming months. So that from the refraction over time, this is a custom chart designed for each child based on their eye growth and the expected level of growth. So we can plot how well this kid was doing on their original multifocal lenses. And you can see here that it was only sort of 14%. And even if we treated this kid, they're still going to end up with a super high myop. We can also then just look at the progression curve. And again, this is 0.75 is super high for -3 myop. For this lady, it's about close to what we expect untreated. So this is where I use the atropine with the contact lenses, which she was in Milo EDOF lenses to increase depth of focus. And I started doing this as an experiment just to see if I cycloplegic the kid, would the depth of focus element allow them to read? And she was absolutely fine. She was N5 with that. So what I've been doing with atropine for the last few years is using it in these high-risk cases once a week, sometimes twice if I need it, but usually once. On a Friday night, if they're not sporty, on Saturday night if they are sporty, so they don't get too much photophobia during their sports games. And by Monday morning, they still have lost a few diopters of accommodation, but they're actually functioning pretty well. And the Myopia Control lenses, effectively for the first day or two, are acting literally as a Presby support reading tool until the drops wear off. Actually, in this young lady, also then she did a weekly art class, just a pair of +1 ready readers over the top. So what happened? From a really fast progression rate in the last few years, her axial length really sort of stopped her in her tracks, and she was actually growing slower than a normal eye would go. So this was an unmitigated success. And when we look at the plotting this period on that same chart as I showed earlier on, where we're just looking at the axial length over time, it's creeping up, but it's creeping up at 100% efficacy or better. So this is just an ideal scenario for what you want to see. Here's another sort of super weird case. Again, just referred in for atropine treatment. So -30, well, minus sort of equivalent of -11 in the right, 4.5 in the left. But some unusual features. I look in kids' mouths with a torch, get them to say "ah." High arch palates, worrying about Marfan's, and she's hyperflexible, hypermobile. Very strong family history of myopia. Not much progression, but she had been started on atropine when she came to me. But her axial lengths, so that was the refraction, so -11 SCR and 4.5, and her axial lengths are barely above normal for her age, with very steep corneas, and the right's super steep. So keratoconus, no, because very regular and a very thick cornea, but something very odd was going on like this. And with this sort of history, definitely something possibly syndromic. On the basis of axial length, vision impairment risk is actually very small. So I'm more worried about making sure that we're going to be treating the right condition rather than chasing this. And the axial length haven't been progressing much in the early phase. And going back to that mechanism map I showed you before, this is why I think this tool is such a wonderful tool for just in an instant glance. You can see here's a kid who highly myopic in terms of the SCR, axial lengths close to normal. And if you look at the top part of this chart here, in terms of axial length compared to a normal eye, Axial length, she's only a 2 diopter myope in her right eye due to axial length, and this is all coming from the cornea and a little bit from the internal lens power. In her other eye, actually, it's quite evenly split. She's kind of a combined everything myope, but not axial. So this lady has been sent off for genetic testing for Marfan's with the family history, and that is potentially a much more important diagnosis than the axial length. But we've also been monitoring her axial length in chemometry, and she's also showing some now actual progression. So she has ended up on treatment, but so far I've not seen any evidence that the cornea is changing. So she started off with a very odd pair of eyes, and we haven't got to the bottom of her genetics yet, but I'm sure we will. And here's an interesting case I saw yesterday, and I got the referral. It came into CERI. And I've blanked out people's names for stop their blushes, but 12-year-old been under care of a community ophthalmologist for 4 years and discharged out of care. Parents into Myopia Control, so they're already on board if you want us to sell it to them. But interesting challenge is outside the range of any of the glasses or contact lenses, and would be suitable for atropine. I mean, there's a few things here that they've been under the care for 4 years already, and this prescription, so this wasn't exactly on the ball early intervention, and also this 12-year-old with that prescription is shockingly rare. And the family history was really interesting. Parents, one hemetropic, one latent hyperope. An older sister growing out of the glasses, almost certainly the same as the hyperopic mum. The 14-year-old sister is as short size as he is. She wasn't in the room. No one else is bad in the family. There's a list of questions that you can run through to pick up, really high pickup for syndromic cases. So retinal detachments are actually very rare. So if you have anyone in the family who's had one, you're using risk of high myopia of genes and also sticklers. Cleft palate, really good for sticklers. Hypermobility for all the Marfan's, Ehlers-Danlos type things. Hearing loss again for that. And heart valve surgery. I mean, one of the risk factors for Marfan syndrome and some of these other odd symptoms. And is this an unfortunate consequence of sudden cardiac death? Now, you cannot ask a mother looking after their child, any sudden drop dead in the family from heart problems and linking it to the eyes. But the question I've come down to is, anyone had heart valve surgery? Because that's actually quite unusual, and in the context of a highly myopic family would definitely point you into some additional tests. One of the questions is, can you see in the dark? And the dad perked up, I've got a big white van, he can't see it in the dark at all. And one of the questions, white screening question, this family lived in, I think, Mayo. So anyone comes from Mayo, great stars in the sky at Mayo. There's no clouds. So can you see stars? He just went, no. And the parents just looked at us and said, I didn't know that. And then I said, tell me about your sister. She's terrified of the dark. So this is a very unusual case of myopia. There's 2 siblings, super myopic, and one absolutely plumb normal parent. So this is just screamingly a recessive genetic cause. And that night vision history and this particular refraction level knocking around -10 or above. This is absolutely typical of this conditional congenital stationary night blindness. And I always say to parents, the stationary is the good part of this. This is not retinitis pigmentosa. You do not go blind from this, but you really cannot see in the dark. A lot of these kids actually don't progress very much. They race to -10 and stay there. So myopia treatments, some people do it, and it's always worth a try if you get them early. But the big sister, I haven't yet seen, hasn't shown much progression. So I'm suspecting this man won't change much. But again, his axial lengths are super long. So if I can stop that getting worse, I will. This actually isn't his ERG. This is another of my patients. But this is a single test will give me an absolute confirmation of this sort of classic ERG picture. So for him, congenital stationary night blindness is a huge safety issue in terms of particularly as they get older and independent. Had one kid with this condition, before he was diagnosed, again, GA player, out on the pitch in the country, power cut. All the kids went back to the changing room, and it was an hour later when they realised that they had that he was missing. and they had to go and find him. So making sure all the friends and the family understand just how awful the night vision is. You're completely disabled under, beyond dusk, this condition. Now, just to, some of these poems are pointing to these rare conditions, and we've recently published a big paper on these if you do one of those My Guides and, you're in the 99% plus, these are the ones to think about. Now, this is a super complicated flowchart there we designed for hospital use. But we made a simpler version, which is this, which is a couple of simple rules. If you see a kid who's got more diopters in their glasses than they have candles on their birthday cake, start to think about other features. And the other features which will really merit the need for detailed hospital-based investigation are reduced best corrected visual acuity, and night vision are real pointers to retinal disease, as in nystagmus, color vision, anything odd on an OCT or imaging is certainly worth looking at. Red reflex for corneal or lenticular problems. And with the medical history, some of the other features of extreme prematurity, hearing loss, developmental delay is a very important one to get reviewed with high myopia. And then with the family history, I mentioned before, some of the retinal detachment, cleft palate, deafness, heart valve surgery. So obviously I see very weird and complicated myopes, and in the community, I think that is the place where the vast majority of myopes should be caught early as possible and put into a treatment that is easy for you to implement in the practice. And then if you see a progression pattern which is weird or something else, refer him. But most of the time, I think 99% of cases absolutely can be handled completely within optometry. But in those 1% of strange ones, there's usually potentially quite a lot going on. And as I said, nearly every one of the cases I've in my large collection of weird cases, they've all been referred into me, please treat with atropine. And numerous people have missed potentially the possibility of something more complicated. So thank you for listening. I'll have to take any questions, and or we can move to Eoin.
Thank you, Professor Ian. It was really insightful. If anyone has any queries, you can put that in the chat box and we can take that up.
Is there anything in there already? Is anyone throwing anything in there?
I have gone through it. There is nothing at the minute. If anything comes up, we can take it after Eoin's session as well.
Yeah, and if anyone wants any of those, so that's, I'll go back up to that. That paper there, the management investigation of high myopia. If you just Google any of those words in my name, it'll come up. It's a free download. It's okay. If you're feeling insomniac, it'll cure that. But it really super in-depth thing of all these things. But those simple rules which are within that paper. So half the paper is written for hospital ophthalmologists, but Sue Cotter, president of the American Academy of Optometry, and Elise Harb as well were involved in this. And there's a whole section based on how to handle this in primary care and how to arrange that process. So, but any questions, feel free to email in.
That's great. And the simpler version of it, wherein you just see if the child's diopters are more than his age, that really simplifies it so much more. So
that's the
thank you
point.
so much.
That plus one more feature. So just is that plus one is a really good sort of lesson.
Okay.
So I'll stop sharing now.
Yeah, I think we have one question in, and someone is asking if you prefer to begin myopia control with contacts.
Depends on the kid. If on a simple case, to be honest, I would start just with glasses. I mean, if I think glasses are going to be enough, and they turn up and they're sort of -2 and they're 10 years old, I'll just going to start with glasses. It's easiest and simplest. I start with contacts if there's an obvious desire from the kid. I'll always ask the question, for sportiness, the GA jersey. If someone comes up and they're 25, 26 millimeters already, and I'm thinking, I want to throw the kitchen sink at them, which is atropine. The atropine on top of a contact lens with the depth of focus element, it works with my sight, it works with EDOF lenses, it works with center distance torics, it works with all of them. They really don't need any additional reading supports for that. So if I think I'm going to go dual therapy, I will go into contacts. If I think the kid will appreciate contacts, go into contacts. But very happily, I mean, I'd probably start more often than not with a glass prescription. Yeah.
That's great. Anyone else has any question? You can put that in the chat box. To begin with our second session, our second presenter is Mr. Eoin Kerin. He is a research officer at CERI and has worked in private practices as well. So he'll be talking about contact lenses in myopia management and affordability.
Thanks, Akshay. Hopefully everybody can see my slides and can hear me okay there. I'm conscious the Olympics are on, so I'll try not to keep people too late as well. So I'm going to talk about contact lenses in myopia management. So the reason we picked this topic, we kicked around a few ideas, and we just felt that this was maybe an area that's still a little bit underutilized in practice. So that paper that Ian actually mentioned there a few minutes ago, that Michael did about trends in prescribing myopia control contact lenses, it's going back a couple of years, but he found that over 2/3 of the practices that he looked at weren't doing contact lenses for myopia management. So I'm not going to try and convince you that contact lenses are the best possible treatment, but it's just to maybe add an extra string to your bow for myopia management in practice, and maybe open you up to being able to offer these to kids who'd be interested as well. So what we're going to talk about. So we're just going to have a look at myopia control contact lenses, what they are, why we should look at fitting them, who we should be maybe fitting them to, and when we should be fitting them to. Then we'll talk a little bit about the safety of contact lenses for children. And then lastly, I'm going to talk about the making myopia control accessible for all patients. So that's an area we just want to shine a little bit of a spotlight on this evening as well. So first of all, what are the different types of myopia control soft contact lenses? So all these lenses work kind of on the same idea. So the concept is of myopic defocus. So the idea is to try and bring that image in front of the retina, and it inhibits the stimulus of the eye to grow, and that should help to keep the myopic changes lower then as well. So we have a few different types. I'm just going to quickly run through how they work. I'm not going to go super deep on the optics because I could be here all night. So the first one we're going to talk about is the dual focus lenses. So that's the MiSight, which I'm sure pretty much everyone has probably heard of at this stage. So they work with two correction zones, so that gives nice clear vision for the child, but it also has two treatment zones using 2 diopters of myopic defocus. So that's what really works for the myopia control part of the lens. I'm going to talk a good bit about the MiSight as well during this talk. So as Ian mentioned, there's a lot of work has gone into studying the MiSight. There's Cooper Vision did about 6 or 7 years worth of research looking at the MiSight. So a lot of what I'm going to mention and the results I'm going to mention are going to come from that research. So what they did, they initially had a 3-year part 1 of the study, which was MiSight for some of the children and then single vision for some more. Then at 3 years, everyone who was in the single vision swapped onto the MiSight, and then at 6 years, they swapped onto single vision then to have a look at rebound. So that's something we're going to talk about in a little bit as well. I'm going to try and bring in some other studies and just mention some other lenses as well, just for a bit of balance, but I'll probably be mentioning MiSight the most. So then other types are your multifocal, such as your bioaffinity multifocal with center distance. So traditionally more used in presbyopia, but also can be used for myopia control. So they have that center distance again, and that's surrounded by the intermediate and near zones as well. And then we have that extended depth of focus lenses that Ian mentioned as well. So that's maybe like your natural view lens. And that works with wavefront technology. So they have the center distance, but then using the wavefront technology, the power changes almost immediately as you move away from the center, and they're able to create this range of focus through the lens. So they're able to manipulate how the light gets through. So your traditional multifocal has point focus. It's able to create this range of focus. Yeah, there is some evidence that the extended depth of focus lenses can be used for higher levels of astigmatism as well, which could be useful going forward too. And then the last one is your novel ring lenses, ring focus lenses. So kind of a similar idea to the extended depth of focus. Rather than having your single point focus, like some of the designs, these ring focus create a ring here to try and create extra treatment effects. So they say that the 7 diopters of myopic defocus through the ring focus, which is able to maximize the treatment effect of the lenses. So all these lenses, like I said, they work on the myopic defocus concept, and they all have 2 benefits. So they correct your myopia, and they also control myopia at the same time. So moving on. So why should we look at fitting myopia control contact lenses? So the big thing, and I guess the most important thing, is we need to make sure that these lenses work and are doing what we want them to do. So the evidence is certainly there that the progression is slowed down and even cut by up to a half in some cases. So with that MySight data, that 6-year data that I mentioned, all ages from 8 to 17 showed slower progression by approximately 50%. So that was all ages. But importantly, the younger ages showed higher levels of myopia control as well. So the younger they were fit with the lenses, the more protection they got from the myopia control lenses as well. Then we also had other studies. So the Blink study looked at multifocals with center distance, and they found 43% reduction in progression with the multifocal lens. And lastly, the Protect study, which is looking at the natural view, so that extended depth of focus lens, they presented results this year at ARVO, and they showed 70% reduction in progression. So there's a lot of evidence there that these myopia control contact lenses and these different lenses used for myopia control do provide protection against myopia control. So that's very important that we know that these lenses actually work for what we want them to do. Another important aspect is that the benefits are retained. So we want to be sure that when these children get to their later teens, or even if one of these children comes to you or a parent comes to you and says, we can't afford these lenses anymore, we don't want to use them anymore, we want to be confident that when we take them out of the lenses, the prescription isn't going to rebound back, maybe worse than before. And so in that MySight study that I mentioned, at the end of year 6, they changed from the MySight into single vision lenses, and they found no evidence of a rebound in that 7th year. So anybody who had been wearing the lenses for 3 years, so those that had changed at the 3-year point into the MySight, or those who had been wearing MySight all along, there was no evidence of any rebound, and the eyes just continue growing at their age match normals. So they continue growing at how you'd expect at their age. So no sign of a rebound there. And there's another couple of studies, one in Spain and one in China, which found similar lack of rebound as well. So that's really, really good. And we can be confident that we're not going to see that bounce back once they come out of the lenses. It does come with a caveat. So if you are taking the kid out of the lenses, it's important to manage their expectations. So let them know there is a possibility that they might need treatment down the line again. And it's also important that we keep an eye on them as well. So just keep a check that there isn't any sign of progression. And if there is, we might need to look at treatment again at some point as well. So just important to kind of keep that in mind as well, that just because they come out of lenses doesn't necessarily mean that that's it, they're done as well. Next up is the advantages over other myopia control modalities. So with contact lenses, there's a few different advantages. They're non-invasive, so unlike your atropine, they are comfortable all day, they're easy to wear, and they also have the benefits that come with contact lenses in general. So your sporty kids, like Ian mentioned, who are out hurling with their goggles on in the rain, contact lenses are a great benefit to them. And also your kids who just don't like wearing glasses. Contact lenses opens up a whole different world for those kids as well. The next point is one that I think is probably secondary in importance to the lenses actually working, and that's how much the patients like the lenses and are willing to wear them. And the evidence that comes from the MySight study is resounding, to be honest. So 95% of the kids who were on the MySight study reported good comfort with their lenses, and 9 out of 10 of the kids on the study said they preferred lenses to their glasses. So that's pretty resounding result. It would also mimic kind of anecdotally what we would see here ourselves with the trials that we run for contact lenses. The kids absolutely adore wearing the lenses once they get the hang of using them. And the biggest question that we have to deal with here is, how do we get the lenses once we finish? So that's all they want to know about. Another question, which I'm sure some people will have in the back of their minds as well, is about handling and how do these kids, especially the younger kids, get on with managing the lenses. And what they found in the MySight study was 85% of the children on the study reported that the handling was easy or very easy after only 1 month of wearing them. again, similar results here in CERI with our contact lens trials. Anecdotally, we see the kids again after 2 weeks of wearing the lenses, and even at that point, you can already see the kids are very confident and very good. Once they get used to wearing the lenses, wearing them at home, practicing at home, the handling is no issue. Just takes a bit of practice, bit of work with the kid and with the parents as well sometimes, but they'll get there. And then the last point I'm going to mention is just the commercial benefits of contact lenses. So taking off my clinician and my researcher hat and putting on a business hat, obviously contact lenses, if the kids are coming back every month, every 3 months, every 6 months, they get their supply of lenses. That's a big revenue generator for the practice. It's also, if you fit a kid who's 8 years old, they could be potentially wearing these myopia control contact lenses for 8-10 years. So that's a continued revenue driver. And they're also contact lens wearer then for life as well. So it's really worth your while from a business point of view, being able to offer these contact lenses. So who should we be looking at fitting with the myopia control contact lenses? So the evidence from the MySight study is that most myopic children will respond to treatment with the lenses. So 90% of the kids on the MySight study responded with slower progression of their myopia. Natural View did a study with the extended depth of focus lenses. Yeah, it was a practice-based study, so it was a little bit less controlled, but they found 91% of the kids who were fit with the Natural View lenses showed slower progression with the lenses compared to pre-fitting with them. So really interesting. It looks like most kids do react really well to wearing the lenses. The MySight study also found that the younger eyes showed the greatest reduction. So I keep going back to that point. It's the younger eyes really benefit the most from the lenses as well. And in that MySight study, just there at the bottom, almost a quarter of the children, so 23%, who wore MySight for 6 years, showed progression of less than 0.25. So really positive that if we fit a kid with these lenses, more than likely they will work. So when should we look at fitting the kids with the myopia control lenses? So again, going back to the MySight data, starting earlier is better. And as Ian said, starting earlier is better. So on that trial, they found fit between 8 to 12 years provided the greatest myopia control effect, but they also found that benefit between the older ages as well. So your 11 to 15-year-olds still got that benefit. So those kids in that trial who swapped over to MySight after 3 years, they still got a benefit from wearing the lenses. So it's never too late either to look at these lenses. And this bottom point is kind of something that Ian already sort of mentioned. We should look at introducing the idea of contact lenses early to the parents and to the children. Plant the seed. So even if they don't necessarily want to go ahead straight away, but if they know that it's available, they can get their head around it. As Ian said, a motivated kid is the most important thing to success with contact lenses. So if you get the kid already thinking about it, already thinking about the benefits themselves, maybe next time when they come back, they might go, okay, let's try the contact lenses. I wouldn't mind them for playing football or playing hurling or something. So yeah, let's move on. And so the last bit I'm going to speak about on contact lenses, and this is probably one of the bigger barriers, both for parents and for clinicians when fitting contact lenses for kids, and that's the safety element. So Mark Bullimore did a lot of work on looking at the safety of contact lenses and daily disposables for children, and he looked at a lot of different studies. He did a meta-analysis which looked at all these different studies which had years and years and years of wear of contact lenses for children, and he found that there was no more risk for a child wearing a contact lens than adults, child or teenager wearing a contact lens than adults. He found there was no higher rates of microbial keratitis or inflammatory complications. And that was similar results were found by Robin Chalmers, who also found that there was no higher rates of microbial keratitis in children as adults. So there's no real evidence there that there's a higher risk of things like microbial keratitis for kids. Mark Bullimore also found that, interestingly, there was actually a lower rate of infection in children than teens and adults. And what he put that down to was there was better compliance in children and also the parental supervision. So the parents keeping an eye, making sure that kids wash their hands before they put them in and out, put them in when they should put them in, take them out when they should put them out. So he found that it was lower rate of infection with children than those older teens and adults, which is quite interesting, I think. The next point then is the retention rates on these studies. So I'm a researcher, so this is something that I love, is the actual looking at the studies and how much the children actually stayed on the studies. So in the MySight trial, there was over 80% retention across the 6 years. So that shows there was no real issue with children having to drop out because they're having problems with the contact lenses. Again, anecdotally, we were running the MAP trial here in CERI, which has been going on for 4 years now, and our retention rate on that trial is in the 80s percentile as well. So there's no evidence there that children are having to drop out of these trials because they're having adverse events or they're having microbial keratitis or anything like that. On the MySight trial, they also found there was no serious adverse event related to contact lens at all in the trial. So that 6 years, there was no serious adverse event, and 99% of all slit lamp observations were grade 1 or less. So really, what we need to look at when it comes to the contact lenses is the risk of the contact lenses, which if we look at this evidence here, there's no real evidence, or it's quite low risk of wearing the contact lenses in terms of all these infection, microbial keratitis, etc., versus the benefit, which is lowering your myopia, which we know the higher you go up, even in 1 diopter, 2 diopters, increases your risk of retinal detachments, maculopathy, all these different conditions. So we need to weigh up the risk of the contact lenses versus the benefit of wearing them. And I think that the risk, or the benefit, far outweighs the risk when it comes to the contact lenses. So that's all I'm going to talk about on contact lenses for this evening at the minute. So we're going to just move on to making the myopia control accessible for all patients. So Ian touched on this a little bit, and it's just an area we wanted to shine a spotlight on here in CERI, because we feel it's very important and it's often overlooked when it comes to myopia control. So often these talks talk about all these different treatments, but they don't actually talk about the kids who maybe are left behind and don't get access to these treatments because they can't afford it. So as Ian mentioned, in the HSE here in Ireland, don't provide a subsidy for myopia control for children. And that cost of the treatments can be a barrier to myopic children. Only last week I was talking to a mum here who had a 14-year-old -6, and she just said she just can't afford myopia control treatment for her son. And that's just not fair. He shouldn't lose out just because they can't afford the treatment, and some other child who just comes from a more affluent area might be able to afford it. So it's something we really need to think about and really need to start having conversations around as well, because we don't want to leave patients behind. So here in the Centre of Eye Research, our research isn't just about finding treatments that work. We also want to inform decision-making, policy-making, and also just have these conversations about societal needs and economic needs within the country. All of our studies here are open to any child who meets the criteria. So we believe we provide, at the moment, an opportunity for practices and for children to get access to myopia control who may not be able to afford it. So in the short term, while we want to change the policy around myopia control to make it more affordable for people, as an alternative at the moment, you can maybe look at referring into us here in CERI as well. So getting access to the trials here in CERI, I have a QR code here at the bottom. This will bring you to a referral form on our website, which you can just fill in with the details of the patients, and we'll be more than happy to see any referrals you send in. At the moment, we have 2 trials ongoing. We have a contact lens trial and a myopia control spectacles trial looking at Stellest, as Ian mentioned. Both trials have no placebo, so there's no control groups. Everybody gets the treatment. So you can be really confident that if you send someone into us, they're getting the benefit of the myopia control. Even if you send someone in and they don't meet the criteria of the trial, or they just decide they don't want to take part in either of these 2 trials, we can still keep their details in our database. And if we have a future trial comes up that they might be more happy to take part in or might be more suitable for them, we'll reach out to them at that point as well. So we're always happy to receive referrals for our trials. So please do work away and send them in, and that QR code will send out in an email after the talk as well. So that brings me to the last slide here, which is actually the big one. So we are very conscious of the fact that if you refer a patient into us, you are referring revenue away from your business as well. So in your practice, if you send us someone to our contact lens trial, that's 12 months that you don't have that patient maybe on contact lenses or buying glasses off you. But what we want to suggest to you is you let us take the initial workload away from you. So if you send someone into us for the contact lens trial, we'll do the initial workload. So we'll teach them how to wear the contact lenses. We'll do the checkups for a year. They'll get free contact lenses for a year. and then we'll send them back to your practice, because that's very important to us, that whoever refers into us, we always send the patient back to them. You'll get someone back then who is a contact lens wearer, and a contact lens wearer for life, more than likely. So let us take that initial workload, and even better, until the end of September, we're offering a generous compensation package to offset any revenue lost by practices linked to the referrals. So what this means is it's a layered compensation package. So when you refer someone into us, there's a compensation related to that when they enroll, and then when they complete the trial. So there's different checkpoints they have to meet. You will get compensated for that. So what we would suggest is, if you have somebody in mind, send them on to us. You have until the end of September, so it's not a load of time to do it. But also, go back through your records. Find 10 patients who might be good candidates for the contact lens trial. That's $5,000 for your practice. So really worth your while to do that. All the referrals have to be through our website, so using the QR code here at the side again. And the practice aren't the only ones who win. So we're also offering a prize for the top individual referrer. So the top clinician who refers into us, we will give a prize at the end of September as well. So it's not just the practice owners who are going to win on this. The opticians get a slice of the pie as well. But on a serious note, this is just part of a long-term commitment here from CERI to ensure that the practice receive rewards for referrals. So the most important thing for us is to make sure that you don't lose out in your business. So our work advances optometry in Ireland and advances optometry globally. So we're involved in work with major companies from America, from Asia, from Europe, and they continue coming back to us to do trials. But you are all part of that work that we do here. So you all play a key role in referring into us. And it's important then that you don't lose out as well. So this is something that we're committed to do in long term as well. So please do consider referring into us before the end of September. And that is everything I have. So if anyone has any questions or any more questions about the compensation, you can send an email in and we can go through it with you as well. So last couple of slides. So that's just what we talked about. So the myopia control contact lenses, safety of the contact lenses, and then making myopia control accessible for our patients as well. A few references. And then if anybody has any questions, the QR code is still there as well if anybody wants to scan it too.
Great. Thank you. Thank you so much, Eoin. And we are absolutely looking forward for all the referrals that you send in. If you have any queries regarding this or regarding any of the presentation that we did today, you can send us a mail and we'll get back to you. And yes, we do take referrals from parts around Ireland, but then, and you can just refer them to us and we'll get back to you regarding how and what we'll do that. Great. I would like to start by thanking both the presentators today. Thank you so much for a wonderful presentation. Can presentations be sent after the lectures? We will be sending you a link, a feedback link along with the presentations today, so that you can get this QR codes and you can refer back to all the slides that presentators presented today. Yeah. Okay.
Oh, actually, sorry. One thing I did forget to say about the referrals. So they do need to be related to the trial. So if you can try and find people who are for the contact lens trial, so sending in your 97-year-old granny won't get you the compensation. So it does have to be relevant to the trial.
Don't try and game the system.
Yeah.
And in terms of actually just risk of getting kids into contact lenses, you can have a long conversation. I have a very short little sort of patter, as I say, to parents who are looking a bit doubtful, who have older kids. Say, look, we turned out that 10-year-olds are much better age to put kids into contact lenses because they have better hygiene and they do what they're controlled, unlike 16-year-olds. And any parent with a 16-year-old girl will go, oh yeah, absolutely. And just setting up those good habits at 10, and they really do just keep them going all the way through. So you can condense a sort of a long message into quite a short one that parents kind of take on board, and they seem to be responsive to that type of messaging.
That's absolutely true. Kids do follow all the instructions given to them, and they are absolutely wonderful contact lens patients. especially if they are motivated enough, as both of you emphasized. So that's really, it's absolutely true, that part of it.
And not teenagers who definitely don't do what you're told and definitely don't have good hygiene.
Yes, that's again depending upon who is coming in. But then yes, kids absolutely do wonderful with contact lenses, and if they are given correct instructions, they are people who follow up to us for more contact lenses in the future. So yes, and Rian has put in the link for the referral form in the chat box again. If anyone wants to copy that link, please go to the chat box and copy that link. Thank you everyone for joining in. We look forward to seeing you in further sessions that we organize. Thank you everyone.
Thanks everyone for dropping in.
So, Mel.